A very good morning to all of you. Welcome again to 4th IIMA International Conference on Advances in Healthcare Management Services, organized jointly by IIM Ahmedabad and IIPH Gandhinagar. Our first session of today is by Dr. Vinod Paul from Niti Aayog. I would like to request Professor Mavlankar to kindly introduce him. Thank you.
Good morning. As we are waiting to be connected. And good morning, Dr. Paul. Can you hear us?
Where are you? Can't see you.
I am speaking.
All the directors are outside.
Maybe I'll sit here.
Yeah. Hi. Namaste. Of course, I'm able to see you very well.
Stage. So,
Okay.
welcome, Dr. Paul. Let me introduce Dr. Paul. Dr. Paul is a professor of pediatrics at All India Institute for several years. He specializes in neonatology and is an avid researcher besides doing very busy clinical practice in All India Institute. He has published more than 350 papers to his credit in very prestigious journals and a lot of international publications also. He has been awarded by ICMR the B.R. Ambedkar Memorial Award for his work in child health, and also an award by WHO called Public Health Champions Award. Last 1.5 years, he is now full-time member of Niti Aayog, looking after health and other developmental issues. With this brief introduction, Dr. Paul, we are sorry that you couldn't join us because of your busy schedule, but we are very happy that you are going to talk to us via Skype. Welcome. I think we can start now.
Well, thank you very much, Dilip. I recall our long association, working with you on difficult times, interesting times, and we have been comrade in arms. So thank you so much for the kind invite. Also, I admire the joint effort, the partnership of the Indian Institute of Management Ahmedabad and the Indian Institute of Public Health Gandhinagar. This is a wonderful collaboration. This is one institution with two campuses in a way in the service of public health of India. I'm sorry I could not make it in person, but I must say that with you and your team and the participants and delegates, truly, and I look forward to our continued engagement. I'm also very, very delighted to be associated with Dr. Sunil Maheshwariji, with whom we share the bond of collaboration, bond of work and values, and also the vision. So very pleased to be here, and I congratulate you for the international conference that you organized. And I'm very delighted to see very young faces and young India in the room. What I thought is appropriate for me is to talk about the Ayushman Bharat. There is a lot that you already know, but I would like to put the twin initiatives of Ayushman Bharat in the right perspective. If you appreciate that perspective, I would like us to understand what it means to the health sector of India and all the players like us and the contributors of this great system and great endeavor, what it means as a change, as a new era. And that has a meaning because we need to recalibrate several things that we do in our profession, in our work, because it is a never before change, and that is the case I would like to make. And I know that there is a session in the afternoon. My discussion, my presentation would serve a trigger for discussion in the afternoon. With these words, my greetings from AIMS, greetings from Delhi, greetings from Niti Aayog. I'm very, very delighted to move on to my presentation. So I'll switch over to slides, and we will join back after slides face to face for discussion and interaction. Switching over. Can you see my slide? All right. So there we are. Ayushman Bharat heralding a new era in healthcare. That is the case I'm going to make. No, you don't do it. But just one moment. We have to get this script. Can you set it up? Just give it one moment, then I can control slides myself. That will be ideal. Just one moment. It was. यहाँ से बचे वही हो गया वहां से क्या I can't okay, so it's moving. Okay, right. So first and foremost, there are two components to Ayushman Bharat. The first one is comprehensive primary health care to be delivered through health and wellness centers. That's one part. The second one is more famous, Pradhan Mantri Jan Arogya Yojana, or PMJ, which we generically call the National Health Protection Mission, but now it is known with a better name, PMJ. What I wish to stress the group here is that one without the other is incomplete. And when we are looking at the importance of what has happened in the year 2018, you must view them together. And I'm using a motif on the right side that you may see that there is, the platform of primary healthcare. Then on this stands the other aspects of our health system, including the secondary and tertiary care. So this will always remind us, this motif on the right side will remind us from time to time that we are looking at a comprehensive effort, a complete effort, a system-wide effort in the name of the Ayushman Bharat. So I'm going to dwell some time on primary healthcare, then I move on to PMJ and then connect this all together. We must appreciate what primary healthcare means. Primary healthcare is health system that provides entry point ambulatory services. So these are outpatient services. Primary healthcare is essentially not about admissions. Of course, first level of care is often added, which is fair. It's largely about outpatient services. And this is about comprehensive range of services. It's not just therapy, it's rehabilitative, it's diagnostic, it could also be palliative. And the third part is close to people. It is next door, it is not far away. And experts like Dr. Mavlankar, who were part of the task force on comprehensive primary health care, said it should not be more than 30 minutes away in terms of services. But an equally important part of primary health care is prevention and promotion activities that aim at creating a healthy society. And this is about tackling the determinants of ill health. We must appreciate that these are the two pillars, two components of primary health care. And when we say Ayushman Bharat would unleash a new generation comprehensive primary health care, we must not forget, even when the program managers may forget, because they will do what is more obvious to do, is that it is about the twin components of primary health care that we are committing up. Okay, done. So this audience knows this, but let me summarize what we know from literature and work, wisdom around primary health care. Countries with strong primary healthcare system have a higher life expectancy than those which don't have primary health care. And this is a very fundamental issue, which I'll elaborate in the next part of the same slide in a moment. Countries with strong primary health cares have also better health outcomes. Their people report higher level of satisfaction with the healthcare system. Often there is less use of medication, and there is a more rational spending on health. We must also remember that this leads to higher productivity and lower healthcare costs, and there are obvious examples in the world that you can relate. Now, the other part is that the problem of non-communicable diseases can only be tackled effectively through primary care approach. This is something very important. You all may know it, but let me emphasize. You know, the hypertension and the heart disease and the diabetes and the cancer were often seen and continue to be seen as if it is the business of tertiary care system, the big hospitals. Actually, it is totally to the contrary. This can only be tackled through a primary care approach, first and foremost through primary prevention, which relates to the preventive motive part of primary health care. How can we reduce obesity on scale? For that matter. On scale, how can we reduce salt pollution? On scale. How can we create a society which wears helmets so that we don't get injured? How can we create a society which believes in exercise, which believes in fit and right diet? That's part of the primary health. And that's something which we must not forget. And I can see public health leadership in the room. We still have to create a great story and a great package of activities, interventions, approaches, intersectoral action to create a healthy society. You all know how much is being contributed by the NCDs. If we are obese, if we are hypertensive, if we are diabetic, this society cannot deliver the demographic dividend that we are talking about. We have to be, it's conditional. Our demographic dividend, our greatness is conditional for us Indians to be healthy. Young people, adults, children, old people in good shape. This is what will ensure that India is great. So therefore, when you look at NCD, primary care works at the primary prevention. Then we come to secondary prevention. Well, secondary prevention is, in a way, a very obvious reason for creating a new comprehensive primary healthcare system. Hypertension or diabetes typically starts around, let's say, 30 to 35 years of age. If it is undetected, diabetes, let's say, there may be a crisis at the age of 48. Blood sugar, comatose patient, blood sugar of 700. And then undetected, an individual may lead to an amputation at the age of 53 or a renal shutdown at the age of 55, a need for kidney transplant. So how do you avoid stable hypertension? Have undetected, a cardiac event may occur around 50s, of kidneys. Same with cancer. If we detect early, we have a chance of treating it, curing it out. But if it is delayed in its detection, then outcomes follow. So the primary care opportunity offers us a situation where systematically these diseases and others, including kidney disease or liver disease, chronic liver disease, can be detected systematically, and then you address it. You address it through good lifestyle, you address it through giving a tablet for attention, and then heart attack is affected. So secondary prevention of cancer, which is the commonest cause, the major cause, the two-third cause of mortality in our country now, can only be tackled through the primary prevention, through secondary prevention, and of course, that there is a treatment to be done. So it is fundamentally important for India that we set up primary healthcare. Without a comprehensive, effective, close to people primary healthcare, NCD epidemic cannot be tackled. And I'm again reminding all of us that remember, preventive motive action is yet to be unleashed in that comprehensive, holistic manner, and not soon. Next one. Well, so this is a bit of a summary, you can say. Primary health care has two sides. One is ambulatory care, the other one is preventive health and wellness promotion. These are the two goals. And of course, primary health care makes it with people. It benefits people, close to people, close to voters. It is close to the needs. It is something which is much more than secondary and tertiary. And above all, to our audience that we are conversing with each other today, a convergent platform for health sector. What is a convergent platform for other sectors that promote health, well-being, and development? Next, please. Well, just to say that primary healthcare is not an apology or a second thought, even on the basis of the examples that we have in the world, we all have to put on record that 80 to 90% of the federal budget on healthcare in UK, Australia, Canada, Netherlands, Sweden is spent on primary healthcare. It is not something that will come free. It is something for which when the countries spend money, it makes a difference, creates healthy societies and people with great health. India's national health policy envisages spending a huge 65% of our budget, state and central budget, on primary health care. So on principle, there is a complete recognition by the policy makers that we need to invest majorly and consistently on primary health care and create a great primary health care platform for the nation. Next one. I'm going to now run through some of the 3 or 4 examples of how primary healthcare, the visionary complete primary healthcare runs in some of the countries. We all must be familiar with the UK system. Here, the general practitioners provide primary healthcare. 65% of their physicians do only general practice, and it is a bedrock, the NHS. All citizens are assigned to a particular practice. They can only go there. Each practice is run by 1 or 2 or more general practitioners. They provide services essentially free. Occasionally, one on 3 pounds may have to be paid. GPs are in 4s and 5s, groups like that, and there are other health professionals such as nurses and the physiotherapists and a team. But very importantly, and we have to move in this direction someday, the general practice acts as a gatekeeper to facility-based care, specialist-based care. I cannot go to a specialist unless I have been seen by my GP. And of course, emergency is a different ballgame. But remember, we are talking about a nation which spends a great deal on health, and we need to bear it in mind. Next one, please. This is Sweden, not very different, a small nation. They have only 1,100 clinics. Team is typically the same, 4 to 6 nurses, physiotherapists, and a lot of population visits these places. They look nice and decent, very inviting. In Sweden, there is no gatekeeping in contrast to what we have in the UK. Next. Brazil. Now we move to emerging economies, and you would see that there are now variations. In Brazil, the primary healthcare teams are organized geographically, covering about 1,000 households. Now that's like the area served by our subcenter. It has a physician, it continues to have a physician and a nurse and a nurse assistant. Interestingly, they have a community health agent full-time, 4 to 6, like our ASHA workers. It's very, very similar to what please. And these CHAs, health agents, visit households every month, just again analogous to what the ASHA workers do. And this is how they provide health care, and it's present all over their country. Next one. We now move closer home, Thailand. Somewhat different now. There is a primary care unit, which is centralized to the district. This system has a hub and spoke. It's called contracting unit for primary care, or hub, covering 10,000 to 15,000 people. You would note that now, for the rural areas, there is no doctor. Doctors are only in the urban center. So we are now moving toward nurse or a mid-level provider-driven primary health care. 2 nurses, 2 public health officers, doctors only in the urban center, and they have a budget. It works on the basis of population, the capitation system is what they follow. And like us, the way we have envisaged, the public health action is linked to these posts. In the UK system or the Sweden system, the GPs are primarily handling only one part of primary health care, which is ambulatory care, and largely the public health action moves in a very different way through municipality. But here you can see the fusion. Next one. Well, what do we have in India so far? At the village level, sub-center level, essentially maternal, newborn, and child health. Few other conditions, communicable diseases in particular. Primary health center has a little more. We have deliveries. It's also a hub for national programs. But very importantly, what it covers is only 15% of the health needs of the society, health needs of the population that it is meant to cover. You would know that a PSC has a population of 30,000, so 1,000 units. What you're covering is only 50% of the condition, and that's where the need for a comprehensive primary health care comes in, and that's what the nation has committed through the IIMA Bharat. Next one. Well, the new primary health care is envisioned in the National Health Policy 2017. A stellar work was done by a task force. And what we are translating through Ayushman Bharat is the vision articulated by that particular task force. The vision is that by the year 2022, when we complete 75 years of our independence, we will create 150,000, 1.5 lakh health and wellness centers by updating present and primary health centers. That's the vision. So a unit, primary healthcare unit, is 30% population, 5-6 health and wellness centers. By each one of them, ASHA worker reaching out to the population. That's the vision. But then, what is it that we are going to do? What do we mean by comprehensive primary healthcare system? So in terms of expanding services, we continue to intensify maternal and child health in a more comprehensive way, particularly if issues like anemia, active detection of tuberculosis as part of communicable disease agenda would be intensified. What has been added already in terms of rolling out are the non-communicable diseases, the hypertension, diabetes, and cancer screening, the screening for 3 cancers at the population level. Adolescent health should be added soon. Mental health is being thought to be added, some are there. Care of the elderly, oral health, eye health, ENT, and palliative care. Eventually, all these 12 components, as the people would like to call, would be put in place. So that's the comprehensive part. Right now, we are somewhere in the non-communicable disease space only. I'm looking forward, we are all looking forward to models that also encompass care of the elderly, the mental health issue priorities, and also model of providing other services. This is the work in progress, but the vision has been set. On the health promotion side, you may recall what we are doing currently is child health largely. From time to time there are campaigns, but when you are looking at holistic health promotion, then we are looking at its integration with Ayush, yoga, physical activity, healthy diet, services for anxiety, stress, depression, suicide prevention, better control, goes on, link it to SWOT, link it to action of alcohol, tobacco, and so on and so forth. So this is the vision. Again, you would see that for a lot of the things that you see on the wellness side, a great deal needs to be done. Where are the models which demonstrate that societies can reduce alcohol consumption? Where are the models of public health which demonstrate that you can change dietary habits at population level? Where are the models where we can demonstrate that the suicide can be prevented at population level? That is one request, one challenge that I'm posing to all of us to address the needs at the primary health care level, the fundamental issues around primary health care and disease prevention, a healthy society. What has been done so far is an effort toward secondary prevention in the space of 3 or 4 major diseases. But the other part, we still have to do research, we have to create models, we have to have demonstration sites to be able to move forward. Then to connect the two sides, we need people's movement and people's involvement by way of a Jan Andolan to create a healthy India. A change of this attitude and this aspiration is only possible when people join hands, when it is people's movement. The Honorable Prime Minister gives a very interesting analogy, and I think it is apt. We are in Gandhinagar, we are in Ahmedabad. He says that Mahatma Gandhi's contribution to our independence stems from the fact that he created a Jan Andolan that was unprecedented. He says efforts on getting our freedom were random prior to his coming on the scene. There were many, many efforts. But there were efforts by individuals, by small groups, by here and there, but not a concerted effort. And what he achieved was that he instilled the notion of freedom and quest for freedom in the minds of everyone. He says, somebody who was a tailor was saying, look, I want freedom. I'm part of the freedom. Teachers, people, ordinary people, all people of all religions, the religious leaders. So he created a Jan Andolan, and that made a difference. And Prime Minister asks us to create Jan Andolan around development, in particular also for health and nutrition. And you would recall in Poshan Abhiyan, you're hearing this word Jan Andolan so much more. But again, a comprehensive health, aspirational health status of Indians cannot be achieved without creating a Jan Andolan. So you leaders of public health here, can we think about how to convert health sector efforts into a Jan Andolan? Next one, please. Well, then this is new primary health care, a little more elaboration, the same model. So we have got more services to be done, but we need more people. So there is a mid-level provider, a nurse practitioner being helped by 2 ANMs, or 1 male worker, 1 female worker, and of course doctor at the PSC. So you bring in at this point in time a mid-level provider to take up the additional agenda. It is quite conceivable that as we move along, we may need more health workers, more additional people, and so be it. Also, more services also includes dispensing of drugs, many more medicines, with interestingly point of care diagnostic for pregnancy tests, for anemia, for blood sugar, for malaria, for sickle cell in areas where it is required, and so much more. Tomorrow this will be a place where blood samples can be taken to a central lab, and lipid profile can be made available. Liver function test can be made available. So this is part of the vision. Next important part is the use of IT to run services, but also to have a telemedicine connect. Of this is an essential criteria that all health and wellness centers will have IT connect with the PSC and beyond. Another important and essential ingredient is to have family health card of every citizen connected to a primary health care card. Eventually, this could even be electronic as the time comes. Wherever there are dilapidated buildings, they'll be updated, there'll be branding, and so on. Next. Well, the first Health and Wellness Center was launched by the Honorable Prime Minister on the 14th of April from Bijapur. Next one, and this is how this place looked. This is the first Health and Wellness Center there. This is his visit to the place. This is the telemedicine connect. He is talking to the patient. On the right side, you see the Prime Minister talking to 2, 1 ANM and 1 mid-level provider. On the right side is a lady, a tribal woman wearing a green green blouse. This lady has hypertension, and she was found to be hypertensive in the range of 180 by 110 through screening. Now imagine if she had not known, it would have remained undetected for a very long time. Again, in the same screening effort, there was a woman with diabetes picked up from the time of community. Just an example, in real life, the real people will be helped through this approach. Next one.
Vinod, you are on slide 15, sorry, but we have to finish by 10 o'clock. So.
Yeah. Oh, very much so. Okay, so these are the new health and wellness centers that are coming up. These are some examples. You can see the branding. Next one. This is what I've already spoken. This is the IT platform going across services to telemedicine. Next one. And these are again the activities. This is the lady that I was talking about. There's another one having diabetes. Next one. This is new stores, medicines, a new list, also point of care diagnostics right in front. Very simple point of care diagnostics that we're talking about. Next one. And this is the branding being done. This is a brand in which you show the plethora of activities of primary health care. Next. Well, now let me move to the PMJ, which of course is so much in the public space that many things are known, but let me give a quick update on this and then try to connect them together. Well, this was of course a mission, started a bit late, and this data that we were planning health care, and we made sure that family health care Ayushman Bharat component precedes as much of the health assurance mission. Next one. What we're trying to do is to cover nationally 40% of India's population at the bottom 2 quintile. So this is the 10 crore population, the red color population that we're talking about. You can see that we still have the unfinished agenda, even in the secondary and tertiary space, of families that are not poor that have to be addressed in due course. Next one. PMJ key features include, essentially, it is about hospital care, hospitalization at the secondary and tertiary level. It's a cover that you well know, ₹500,000, 10 crore people, 10 crore families, and more than half a billion people. Please note that this is 2 quintile and in a way more than the BPL. It's no more about BPL type family. You are already into the BPL categories in a significant way. Certification happens with Economic and Caste Census of 2011, which has already identified families, inaccuracies apart, for certain criteria of vulnerability. Next one. Well, very important feature, and this is a paradigm shift in a way, is that the hospitalization will happen through this health insurance system with both public and the private. And therefore, this scheme has united the two sectors together into one sector for practical purposes. Next one. It's being implemented, as you know, in alignment with the state scheme. States are putting typically 40% of the resources, the center 60%. For hill states and northeast, the center puts 90% of the resources and the budget. Next one. Just to highlight things that are known, age is no bar, pre-existing illness is no bar, family size is no bar, no formal enrollment is required because the database is already there. Validation by any entity, not just Aadhaar, transparent, cashless, paperless process. Next. Okay. Well, the packages. Are we on packages, Dilip?
Pardon?
Are you on packages?
Yeah. Correct.
So there are 1350 packages. What is important to recognize is that these cover practically all the situations, including the cancer, the heart disease, the knee replacement, intensive care, newborn care, gynecological conditions, fractures. It's practically everything except transplant and cosmetic surgeries. The rates have been decided based on the market detect rates of various state schemes, but wherever the cost data was available, that was the prime way of estimating the cost of these packages. Something which is often not known to people and that becomes a reason for criticism is the flexibilities that are around the packages. States can add 10% more for each package. Accredited institutions, fully accredited and NDH accredited institutions can 50% given package. If you are located in the backward district, the aspirational districts, the package rate was higher by 10%, and very importantly, if you are running a PG or a DNP system, so medical college hospitals and DNP hospitals would charge 10% more because they think it's a stimulus to education as well as it is a better system in terms of coverage. State schemes have been aligned, as you know. Next. Huge effort was made to reach out to people. Next. So sabhas were done just to educate people. The efforts are still going on in different ways. Next. The Honorable Prime Minister has written a letter each to the family, and this letter itself also serves the purpose of your identity when you seek services. Next. CSCs and above, all public hospitals are empaneled. Private hospitals are empaneled based on a criteria. Responsibility of empanelment and running the scheme is the state health agency, and we have a norm of settling the claims within the next one. This is to say that the beneficiary goes to a help desk where Arogya Mitra identifies your name on the screen on SEC database. Based on them, you say, this is my identity, I am the same belief, and once it is identified, you want to take the care in that facility. And the package includes hospitalization, treatment, diagnostics, and 2 weeks of therapy after discharge. And also the food is included. And this education is given by Arogya Mitra, and then we are making phone calls for the feedback. Next one. These are some other materials. Already these IIMA Mitras are employed. 15 of them have been trained. Already it is creating interesting new jobs. Next one. Other material. This is the website. Next one. Work in progress includes creating standard treatment guidelines, which can then be embedded in the treatment pathways. And also, cost of care studies are urgently required for defining the cost of packages for future. Huge effort on fraud prevention, detection, and deterrence, including how we identify hospitals, how we identify beneficiaries, also to use technology, also to use artificial intelligence, and to also have deterrence by way of punishing the defaulters. So this is very, very integral to this whole effort for a country like ours. Next. For this audience, just half a minute stopper here, that technically PMJ could run as the trust model or an insurance model. So we have a state health agency whose job, which is a society of the government, job is hospital empanelment, beneficiary identification, awareness, and fraud prevention. But if in addition, the same agency also does claims management and hospital interface, then it is a trust model. But if for these two functions, you have an insurance intermediary, then it's an insurance model. I'm pleased to tell you that by and large, PMJ is a trust model. There are only 5 small states which are using the insurance model. So this is something which was a big debate for a long time. But ultimately, at least for the time being, we have ended up as a trust model based health insurance system for India. Next. This is the progress report. We like to know 4 p.m. yesterday. As you know, 4 states are still not in the ambit. Telangana, Orissa, Delhi, and West Bengal, of course, was there and they withdrew. We have 15,000 hospitals empaneled. Half of them are private sector hospitals. 1.2 million, 12 lakh plus individuals have been benefited. the scheme till yesterday, less than 4 months since the onset of the scheme. Claims worth 1,100 crores have been submitted. 900 crores of them have been approved. There was a big criticism: would we be paying on time? Not. This is a very important commitment that payment must be made. And just to say that the whole buzz about people asking questions, and the call centers are busy and they are responding to 2 million calls. Next one. Now coming to the last part of my presentation, I'm making a case why Ayushman Bharat is actually a game changer for India. Next one. Firstly, as you will see, it will increase access. Now imagine Ayushman Bharat together, primary healthcare and universal health coverage. Together, it will increase access to healthcare, both primary and secondary, and therefore, it's secondary and tertiary, of course, all the three levels. So better health and longer lives, prevention of illnesses, primary prevention, secondary prevention, and then if you are under, whole range of access is now possible for the people of India. Next. Second, eventually, it will hit the out-of-pocket expense and catastrophic health spending. Next one. And this is something which I would like to show you from how this will happen. On the left side is a pie diagram, a very familiar notion that emerges from this illustration, that a lot of out-of-pocket spending is about medicines and diagnostics. And this is something that would be addressed through the primary healthcare component largely, because that's where this happens. So imagine a situation where most of the drugs, the first-line drugs and diagnostics are available to all the people. So this gives a expense eventually. On the other side, I also want to emphasize that hospitalizations, the encircled top, 32% of the out-of-pocket expense is on hospitalization. It should not be forgotten. And this is also rising according to the data studies that are available. And this is actually, you can see in this one, the size of this has increased over 2 period. This is natural health. So this is the spending that would be covered by the health insurance PMI. So eventually, a difference. In the more proximate period of time, the catastrophic spending for the people would be reduced, because they will now, the beneficiaries should not be selling their house or selling their rickshaw or their livestock to seek care. But remember the access part also. These are the people who were perhaps never reaching out to care, for whom now the care is available. Next one. Infusing quality, because we are using a criteria on hospitalization, and we follow the standard treatment guideline adherence. That's one way, and of course tomorrow we can make a QI, QOC system in any hospital is a criteria before environment happens. Affordability is an obvious one, but also private as well as the public health system has now become more accountable, because we are taking feedback directly from the patient to find out what kind of care, respectful care, effective care, non-corrupt care has been imparted through the network of hospitals that have become part of BPMJ, as well as, of course, the same paradigm of primary health care. So you can infuse accountability from both the public sector and the private sector. So push toward quality, affordability, and accountability of the health system. And your leadership here, people in this room, you can build on this notion and create tools and systems for the same. Next one. Massive investment is now likely. We need some 2,500 to 5,000 new hospitals. We need to double the secondary, tertiary beds, jobs, services. Health promotion will become a way of life. More people will be engaged in this. Technology adoption, technology prediction. And we believe a lot of action will be in tier 2, tier 3 cities. Future is for small and medium-sized hospitals. And also, it is important that the private sector contributes toward training of specialists. But there is this big push of investment and growth in the health sector in immediate and medium term. Next one. We will continue. It's no intention of Ayushman Bharat to compromise the public health system at all. The push for public health system will and must continue. It will be interesting for you to know that public sector earns same amount of money as private sector earns for a given procedure, and this money that you earn is kept at that hospital to be used as compensation to providers or to create additional facilities or to buy an ambulance or to buy monitors, and this money is an additional resource for the public sector hospitals, medical colleges, district hospitals, and so on. This is embedded in the design of the. But last time, toward the end, it's also a system level change in the health system. We are now looking at the public and private as one network of health system. But there's more to it. Next one. If you see, this is the current situation. That we had 15% of our services in the primary healthcare space, building on the health priorities. These round and open bodies are the health priorities. There was 85% unmet need. At the secondary level, we strengthened the district hospitals for maternal and child health. Those are the ovals and the rounds. But we didn't do it for, let's say, abdominal surgery or breast cancer surgery. As a tertiary space for that matter, or care of child patient with jaundice or prostate. Yeah. This is the picture that we were addressing. But the health system is poised now to change in size. I talked about that in terms of nature of having high volume, modest cost hospital, price, reach, standards, and responsiveness. Next one, please. But what is also important is that we are now looking at this paradigm, where it is comprehensive primary healthcare platform, which is in a way agnostic to individual diseases. Everything is to be covered. Secondary level, all conditions have to be covered. Our prioritized way of doing things, of diagonal approach, of set of priorities, is now moving on to comprehensive approach, the systematic and the system-based approach, which is needed for our own health goals as well as for SDGs. And eventually, we will have a gatekeeping system placed once the comprehensive primary health care system is set, and we will bring in also perhaps a capitation model. So you can see the holistic, this is the level of change. The change through Ayushman Bharat is across the system. Primary healthcare, secondary healthcare, tertiary healthcare, and this is the point of change, the inflection point in the history of health sector of India, which I want you to appreciate and be ready to respond to this. Next one. Well, it is now, health is also a center of debate, political debate, development debate, and that's what Ayushman Bharat has done. And last of all, next one, will help, alleviate poverty as we have had people who perform more, who earn more. It will reduce inequity and lead to a healthy society. And we also believe that, when the state governments are putting their own resources, the gain is well beyond 40% of the people. It will, even in the immediate, maybe in the next year, you may say that the beneficiaries of the health insurance mission in particular may be as much as 70 crores or more. And therefore, this is a big push towards universal health coverage. And therefore, in the end, let me just say that this Ayushman Bharat, both on the supply side as well as on the demand side, as well as on the financial coverage side, as well as expansion of health services, responsive health services, accountable health services, is what Ayushman Bharat signifies. And we are now truly taught to achieve universal health coverage through Ayushman Bharat. Thank you very much. I am switching over to the visual.
Yeah. Thank you. I think excellent and very clear. I think the slides were also very, very useful and clear. So let us open for questions, quick comments. We have about 10 minutes because we started 5 minutes late. Anybody? Yes. Let me ask Sudarshan Jain, who is a IIM alumni, and here, please introduce yourself, those who ask questions.
So thank you very much, Professor Dilip Mavlankar, to invite me, and thank you for excellent presentation, Dr. Vinod Paul. I've been hearing you being the Vice President of OPPI and ex-MD of Abbott. It is great to hear you always on this presentation. I just wanted to understand the status of primary healthcare scheme, what you talked about at the moment, and how do we take care of the manpower requirement, doctors, nurses, paramedical people at the primary healthcare centers going forward? Because that is going to be game changer, as you highlighted extensively in your presentation.
Now the second question is also in the same line, so maybe there are two questions.
Just articulate the question. I missed the exact words, but can you articulate the question?
Question is, primary healthcare centers are going to be the game changer going forward. How do we meet the manpower requirement in terms of doctors, nurses, paramedical in those centers?
Okay, I think this is a very, very fundamental issue. The biggest challenge and the biggest threat in a way to our aspirations for the health sector are in the space of HR. And let me also say that our maximum challenge in this regard is to have enough specialists. Often we everything in general. This challenge is really number of specialists that you need. We need at least 5 times the current number of the specialists. I can come back to this in this time in terms of specific. But if you look at typical specialist scenario, we are 1/10 at the population level ratios for what the Brazil and the Japan and the UK have. But even if you have to be modest, like Thailand, let's say, or like some middle-level countries, we have to be 5 times. How do we, move to 5 times situation from, let's say, 60,000 gynecologists to 3 lakh gynecologists and 6 lakh gynecologists? That is the biggest challenge. I think that needs a little bit different approach for discussion. I come back to that. But for the primary health care, we are in a reasonably better position because the current paradigm relates to having nurses who have BSc degree, who can be given training partly on site, partly in the beginning 2 weeks training, and then you can have them trained in a staggered manner. So that's not a very difficult thing, although our effort on this needs acceleration. Our original model was to use IIMA-based training system. But I think we have more or less cracked. Now the training is being accelerated. I'm happy to inform you that 7,700 health and wellness centers are already working. And our target for the first year is 15,000, which we might be quite close to. I'm also happy to tell you that 13 lakh people were screened for hypertension, and we now are actually in the business of performing. So I think the challenge is really HR. If you look at doctors, you are 1 for 1,600. If you're 1 for 1,000, we are happy. The issue is this is about 2x situation. But I just now mentioned to you that when we're looking at surgeons, our needs are very difficult. I'm happy to take those questions later. But that involves the regulatory system and PNB system. Some solutions are available, but you guys are the smartest in the country. Please send us suggestions on how this can be accelerated. But if you feel it's appropriate to talk about HR issues, I'm happy to give you a 2-minute story on that, and then I invite questions. But I would like to wait for your suggestion. Thank you.
Yeah, some more questions, comments, anybody else? Yeah, go ahead.
Myself, Sharad. Actually, my question was related to that only. But apart from that, I would like to ask you, on basic level, if you are talking about modernizations of that PSC and CSC and first after unit, so how you tackle with if talking about the telemedicine, if the country like our India, in PSC level, there are 10 to 12 hours of electricity power cut. So how that telemedicine will work? And secondly, I would like to ask if you are going on a public-private partnership with the private hospitals. So I found that, personally I found that I was working with one hospital, and it was the CT scan machine, and that is will be a public-private partnership. But that machine is available in hospital, in government hospital, but that is not working just because of that the PPP model is going on in other private hospitals. That private hospital that machine was working, and our hospital was not working. And last, my question is, you are integrating Ayush also in that new policies. So already the critics is going on there, a lot of critics is there. So my question is, how and where that Ayush graduates will be placed? Are they will be a doctor, or are they will be the assistant, or only the attending persons?
Okay, loaded questions. Let me begin with the first one, telemedicine. I think for all practical purposes, we must remember and take cognizance that telemedicine, IT, telemedicine in particular, will play an important role in the delivery of services, particularly the primary health services. It's a given. We have talked about a telemedicine connect in which the mid-level provider with a doctor, or for that matter, a specialist, and for that matter, a team of people sitting in the cabinet. This is to make sure that a conversation can happen. You can talk about patient, prescription, idea can be given by a higher up which is being followed. So it's integral, but I want you to actually be mindful of the fact that the reach of telemedicine, this is oversimplified, small, minimum. If you go to Andhra Pradesh, they have a full urban PHC system linked to things. And they have recently gone to 5,000 sites in the rural areas with telemedicine. I think we already in India have wonderful prototypes and early implementation of telemedicine networks embedded around the healthcare system. One good prototype is in Polar, if you like to say, in Andhra. So I'm only saying maybe next year let's have a meeting in which we talk so much more about telemedicine. I think no way you ignore it, and there's so much potential for telemedicine in terms of reach and the quality and developments and participation and partnership that is almost integral to how India delivers value. I just leave it here. Fascinating model already operating in the urban PSC statewide, 2 PPP in the organized state. Your second point was in regard to Ayush was third one, so let me answer that. Well, Ayush workers to be trained at mid-level is only accepted by the state of Ayush. Other states, all of them are going via the route of the nurse practitioner, nurses and so on. Yes, there is about how this has to be bridged. It is for the states to bridge. We have given them choices, but much of the country is moving forward through the nurse practitioner. Your third issue is on the PPP. Yes, there are workable models and there are rotten models of relationships, but I please remember that in the space of technique and particularly tertiary, there is a private sector out there which you and I make use because we have some money in the pocket. What Ayushman Bharat PMG has done that you don't really telling this population, wait till we build this. By the year 2060, then we will make it open. Why are we asking this to us? All of us go to the private practitioner. So what if the country has, and this is a hardly anybody has objected to the basic design of PMJ. Yes, poor people, we have this much of private sector. They work on our terms. There is no profiteering. Our package rates are the cost at AIMS and cost at Ahmedabad public hospital. It's no different. So it's not a leap. But just as you are able to access private sector, the health insurance with the financial brace is now able to access. Now it is for and me, you, Dr. Bhavlanda, Sunil, we have to make sure that we create models that can work seamlessly within the law of the country within the democratic system of the country, but also with the ingenuity of the smartness and the intelligence and innovative mind that we have. We have to create a system, and an autonomous system doesn't justify the throwing away the hand.
Okay, any other quick questions, comments? We still have 5 minutes. I have one suggestion. I'm looking for hands for questions. I think one thing which RSBY did not do, and maybe learning from that, is to quickly make the data available for outsiders to do analysis, anonymized without compromising anything, but as we go every quarter or every whatever, so that, because all this audience is researchers, PhD students, MBA students, MHA students, and some teachers. So they would love to have such access to public data, because sometimes we know our public data is more private than private data. Private data can be at least purchased, but public data doesn't easily become. So that is one quick point I wanted to make. You don't need to respond immediately, but there is one more question.
Yeah, good morning. My name is Prachi Mehta. Thank you for the very informative presentation. I just have a question about what kind of framework will be in place to monitor the reach of this particular initiative, and also to make sure that it's being used and evaluation monitoring. I'm just curious to know. Thank you.
Well, both are government initiatives. For the PMJ, the Health Insurance Solution, I'm pleased to tell you that we now have a National Health Authority, which is an independent vertical created within the Ministry of Health, which is directly reporting to the Honorable Health Minister. It is no more controlled by the ministry per se. This should augur well. This should give you confidence that you can build governance models, which are a departure from a standard model, right? So already India has taken a very major step, that you have a independent, autonomous, empowered governance structure at the helm of affairs. If we had done it 5 years from now, we would have already created a big mess. So this is a huge, this should be seen as a strong point in the commitment of the basic to act well. Therefore, that authority has been created. It has ways and means of monitoring. There is data reporting. There are feedback systems. There is a team of already about 180 people working like a hub. There are at least 20 people working at night, solving problems in various areas, and a lot more will be put in place as we learn. On the Health and Wellness Center, that model runs largely within the government system itself, because it is embedded in the larger context. It's not very critical, it's more difficult to learn because it has 500 variable points, and then the PMJ is very straightforward managerial delight, whereas the Health and Wellness Center issue is primarily healthcare and there's so many variables, but it is being run in a certain way. I want us to remember that often NHM has created some difficulties of a certain kind for governance in a certain way, maybe not, but then we delivered. So you created NHM and you delivered 1,000, and today giving 12 million were otherwise dying. So you're saving so many lives, and this is India's innovation. India can set up a governance system, and you are the smartest people on management and governance. I want you to we create, develop, that will deliver of Ayushman Bharat and beyond.
Okay, any last one question at the back and then we close? Yeah. Please identify also yourself so Dr. Paul knows.
So I'm John from Tata Institute of Social Sciences, Mumbai. My concern is that in the rural areas where we have functionally weak primary health center and so on, we have the NGOs, the not-for-profit sector working there. So are they given enough space in this Ayushman Bharat scheme or PMJY to work with the government? And the second aspect is in training the nurse practitioners. the missionaries have actually inculcated a spirit of service and commitment among the nurses, and they have brought the career as such. So are they given opportunity to train nurses so that they would become very committed and empathetic nurses?
Well, the answer to this is that only health and wellness mission is in the early stage of opening out. There are such choices being offered by the state governments, picking a partner. Sometimes they pick up an NGO who can run a few institutions. At other times they may say, okay, we'll involve an IT firm to do the IT part, or involve somebody to look at the diagnostic. I think this story is unfolding. In principle, engagement with NGOs is possible to, state government, because they are the ones who are running it. But if you say, are we going in a big way, reaching out, and we have RFPs, I think that has not happened. Should it happen? Yes. But I think that's some, I haven't good response from put this in the space for data eventually being available. I want us to remember, the academics who are sitting here, can you help us create the right function of the health and wellness center? How to ensure that the depression can be tackled, and ensure that people come and get these services done. How can we ensure compliance? How can we ensure that the screening is done? By the way, I just want to give you the right number on screening. We have screened in for the last few, since the onset, 10 million people, and exactly 9% have have a diabetic state. Just to tell you, this epidemics of diabetes, 1 in 10, hypertension 1 in 3 is a huge problem for India. It actually is only one part of the story. Please mark this. We are not used to handling health of NCD actively. The research only shows that I can screen. Can I ensure compliance? I don't know. Is it you can't ensure compliance, or is it like ensure lifelong compliance by diabetes? We all are might together to create and to take using technology to answer this is just platform has been set. A game changer initiative has been critical toward health. We must.
Thank you very much. I think Skype is also tired. Your last sentences were getting cut as but lovely. I think it was very excellent. Thank you very much for taking out time on a Sunday and speaking to us. We would have loved if you could have come here, but I hope you give us permission to circulate your presentation so that and video. We have also recorded this on video, so we can put it on the website so that many more people can understand and appreciate what Government of India is doing under Ayushman Bharat. Thank you very much, Dr. Paul. Thank you for the patient listening.